Thank you to Terry. Thank you, Robert, for supporting this lectureship. And hello to all my friends and colleagues. I know many of you and have seen many of you recently in other venues. And it's such a pleasure and honor to be back down. And I did talk to Terry about what to speak on, and we settled on a topic I suspect you've heard about before, and I've certainly spoken in other venues. And I try and keep it updated and kind of current and a little bit new, but some of it maybe some of you have heard before. Hopefully some of it, though, is new. This space is actively connected to industry, and I've been involved with research projects, and so all my disclosures, of course. But what I'll speak about is, again, how I view the clinical world and share that with you. And so I have the pleasure for the next 45 minutes of really walking you through this outline, which is a very quick approach to why we really are into the molecular space and what the problem is. I'll give you kind of the landscape of the space, but I'll spend most of my time hopefully really focusing on the good, the bad, and the lessons. And I think it's the lessons that have really taught us the most. How are we thinking about the right questions? What is the optimal hypothesis? What is the practical limit to any test? Why would there be a practical limit? The theme that you'll always hear me speak about is kind of the importance of high-quality clinical validation, and increasingly we're seeing more and more of that. What I won't tell you is a single best test to use. I'm not going to go that direction. But I will start kind of clinically. I see myself as a clinician very much. I see patients every week and biopsy patients on a regular basis. This is a typical patient, right, that would come into your office, my office. A 48-year-old female found to have an incidental nodule on a CAT scan, completely asymptomatic, has no prior thyroid problems, and she's in good health and has on exam a roughly 2 to 3 centimeter nodule. She has a normal TSH. It moves when she's swallowing. It's kind of a run-of-the-mill typical nodule. And the question always is, what do we do in the next step? It may look something like this. This is a much bigger nodule, probably more like 5 centimeters in someone with a very thin neck. I usually use this as a lead-in to share with you. If you haven't seen one of my favorite pictures, this was a true story. I was reading Time magazine over a decade ago, when even on the cover of Time magazine, you see the same problem. So if you don't believe me, I'll show you. Let's see. So without doing the wires, thyroid cartilage, sternocleidomastoid muscles, a little nodule there in the left fossa. So this is the starting point, which I think everyone knows. This has been the kind of process for evaluating a clinically relevant nodule for the last 4 to 5 decades. As ultrasound has become now so good, it is by far the optimal imaging modality for the gland. We check serum TSH for the off chance we find a functional or hot nodule. That is the rarity. Almost everyone heads to the bottom right of this slide, which is heading towards FNA and cytologic analysis. This is the routine distribution of what you will find from any large-scale series of fine needle aspirates. The cytology works itself out like this. The reason FNA cytology is so good and was so valuable so many decades ago is that roughly 2/3 will come back with a true benign result, and we believe that is very accurate. Even the false negatives are really no risk to the patient, and that's what really stops the train and is, for a minimally invasive process, so good. A rare portion will be malignant, but the biggest issue is this indeterminate category, and you see Bethesda 3, 4, and 5, kind of, so we have common terminology. This is the group where malignancy hasn't been excluded, and yet we are unable to really conclusively say whether something is benign or malignant. And the problem is this. These were our data now a decade ago. We're going to update this in the months to come, but essentially when you look at large consecutive series and ask the question, why is it that we could do better? You compare the final aspiration cytology on the left, those indeterminate categories, to the findings on the right, which is if you did take them to surgery, how many prove to have cancer? And you see that the minority actually do, that we could try and prevent unnecessary surgery for at least 50% of those cytologically indeterminates. So that really is the lead-in. Can we do better? It's been the lead-in for many years as we've talked about this, and I think we can, and I think molecular analysis, with its caveats, is also leading us forward. But before I go just to molecular analysis, I want to share kind of a broader thought and bigger picture and share some of our recent data as well, because it's not all about simply a singular mindset to kind of move forward with ultrasound and then into molecular cytologic and then molecular analysis. I wanted to share with you this kind of scenario. What if a 71-year-old patient came with a nodule, again found on a CAT scan? She also, as many 71-year-olds do, may have had a solitary lung nodule that has been stable on repeated CAT scans for maybe 2 years. It's felt to be likely nothing. She had a stent placed for coronary disease a couple years back. She has hypertension, she has gout. And on ultrasound, she has a 2.3 centimeter isoechoic nodule, and they called out maybe there's some colloid, can't really tell, no lymphadenopathy, and what would you do in this case? And many of you may say, and myself included, this seems awful similar to what I presented the case just a couple slides back. But this has really caught our eye as the whole field, I think, is moving more and more conservative. We have started asking what many have been asking in other ways, which is, do you really need to do anything? And so one of the opportunities we've had is that we've consecutively collected a very large database of nodules that really captures our whole system at the Brigham. And so we began to say, you know, is there an age cutoff where perhaps intervention can be limited? Or at least what is the analysis of risk to harm to benefit? And so we have had a collection of well over 10,000 patients consecutively, 20-some thousand nodules. But when we looked at just the population then over age 70, we had roughly 1,100 patients, roughly 2,500 nodules, kind of routine, typical patients. The nodule size is about 2 centimeters or so. And we asked the question then, if we looked into their medical history and then what happened to them moving forward after their time of presentation, and we looked in specifically at the risk of mortality from all causes, what were we beginning to find, and how could we then give better understanding to thyroid nodule care in this population? What we found is that 17, that's it, only 17 of the roughly 1,100 ultimately had high-risk thyroid cancer as defined by the typical criteria, metastatic disease, etc. And in fact, all thyroid cancer deaths fell within that group. But it was a very telling finding to us because when we began to, of course, look at this population, you do find the typical expected comorbidities that roughly 1 in 5 have coronary disease, roughly 1 in 3 have some other malignancy for which they're receiving treatment. And because the patients that are often being found to have nodules on CAT scans for other reasons, etc., they often also have other illnesses that will cause mortality. So over even 5 years, 1 in 7 of those patients died of a non-thyroidal cause. But this allowed us then to ask a question, well, what was the number needed to detect one of those high-risk cancers? That's the benefit you gain, right? Because they were going to die from thyroid cancer, and it was 1 in 66. But then you began to ask, what is the number needed to harm, just from the true operative side effect? This was not just the morbidity of an operation, but truly there was a hypopara event, there was a reoperation, there was something, an infection. And it turns out we were hurting about 1 in 49 patients. And in fact, when you just said the morbidity of unnecessary surgery, we would argue that it's 1 in 13. So the numbers here were not looking good. But what was most notable is that you could pick up these high-risk patients, the ones who would die from thyroid cancer, simply with preoperative ultrasound and FNA. They were identifiable. And it really begs the question, which is I think where the field is moving, which is you could make kind of a statement out of this that maybe patients over 70 may not need any nodule evaluation if their ultrasound is somewhat unremarkable or the nodule is low risk. That's a loaded statement, but I think it's one where the field is moving. I want to also give you kind of the other end of the conservative spectrum and have you consider this. A 59-year-old referred for evaluation, and she says, you know, this small nodule has been there for years. Doctors have found it and just left it alone. But finally it was worked up and there was a 1 centimeter nodule on the left. It had some microcalcifications, but no lymph node disease. And so it was high risk on ultrasound, and it was biopsied and proved to be papillary carcinomas, positive on the cytology. And what would you recommend? I think most of us would say, boy, once a patient knows they have cancer, it's likely you're moving down the track, right? And you're going to have this surgically removed. But I think this is also taking hold. That these are the data now out of Japan. This is a recent kind of meta-analysis by Ito and his colleagues. This is in the European Journal of Surgical Oncology just this last year, where he put together what essentially is his reflections and his data on roughly 1,500 patients from 2 different centers where they did nothing. They watched it. It was a conservative management of a known malignancy. It is low risk, so they had no nodal disease. The nodule was in a unique location, not specifically close to any vital structure. It was roughly 1 centimeter or smaller. But there's now, I think, increasingly good data that when you look, for example, at Kuma Hospital, they had roughly only 8% over the course of about 10 years that showed growth. And it was the younger patients that seemed to grow more than the older patients. That was somewhat replicated at their second hospital. But the bigger point to this is not to say that some of these couldn't get bigger. It's to say that you can safely watch them because intervening on those that did get bigger later seemed to be not harmful. You could actually catch them, and the so-called rescue surgery was not at all harmful. The delay was not harmful. So I think those are two big grounding points as we start a discussion on molecular analysis, is I don't ever want to give a feeling that we need to perform molecular analysis on everyone. I think that's the wrong mandate and the wrong discussion. So kind of what is the lesson to be learned as we kind of start that discussion? I think it's that not all nodules require evaluation, and at times a conservative approach is absolutely reasonable and at times even preferred. But for many relevant nodules, this is the pathway that is followed, and it will kind of lead us forward. Now, again, one more step back and a quick tangent before I talk about molecular analysis, which is to say we absolutely do individualize care, and we should individualize care. That we would argue going into analysis of any nodule, that nodule would carry roughly this 8 to 15% risk of malignancy. But there are clinical factors. There certainly is a gradation of risk using FNA cytology. There are many radiologic variables that will begin to allow individualization of risk assessment for each patient. But the reason this has never through the decades, I think, made a meaningful difference is when you modulate risk between roughly 10 and 90%, clinical decisions don't seem to change. I think you really have to push the risk assessment out to the extremes, and that's where we've begun to see that people will either stop clinical care and be more conservative or find that they really need to move forward with something. And that is why I think the power of molecular analysis really got off the ground, that we were able in some cases to say we were pushing to this kind of predictability. So that's really my long introduction to discussing now the space, molecular space, and why I think there is some good here, but also some bad and many lessons. I like to always lead with this slide. I think this, first of all, is kind of the simplistic way I think about the cellular replication in our bodies and how we think about molecular analysis, that we have DNA in most of our cells that is transcribed to RNA, which is the signal, and then also that is the signal from which is translated the proteins that do the function of the organ or the cell. Over the last 20 years, there's certainly been a big understanding that we have a negative inhibitory regulator of this last translational step, which is a group of microRNAs. What is very interesting in the thyroid world is that from the start, back in 2000 and probably a decade ago, we began to see molecular markers that were being talked about for their translatable effect into the clinical world in each of these buckets. And now I'll just kind of explain what we see currently in the landscape is clinically. I'm going to start with the proteins and move back because they were the earliest kind of out on the block. When we think about the use of protein staining for the evaluation of thyroid nodules in Indeterminate Cytology, the hypothesis is that cellular proteins are either over or underexpressed in association with malignant or benign disease. And you can measure this. It is also tissue specific. And though there is some subjectivity to how much is expressed, you can make this somewhat semi-quantitative. And the classic, though there are several immunostaining options, the classic really is galectin-3 that has been used, and I'll come back to that with the trial here later on. Moving kind of into the next bucket, we have the microRNAs, and these really are the youngest in the group in terms of getting out clinically. The idea here is that these are non-coding post-translational modifiers, usually inhibitory modulators of that last step. There's actually a confined number of them, I think felt to be about 1,000, but they do associate with malignant or benign disease. And like any RNA, they are expressed. And so the question came up, could you measure that expression, strong, weak, negative, positive? Yeah, a number of them, and through some analysis, create some sort of signature. This has been taken forward by two commercial companies, Rosetta, and then I believe Thyromere is an Interpace company. That was the new company that took over, I believe, Asuragen. I think personally there's not enough strong kind of a phase 3 equivalent data for this bucket and for these tests, and so that's why we're also not seeing insurance coverage for them as well. The main scenario, the main use here out there is kind of the RNA-based and then the DNA-based test, and I'll talk through them. There's only one RNA-based test out on the market, is the Afirma, the gene expression classifier, or now the gene sequencing classifier. The concept here is about a decade ago, both the price point came down and the technology became available to measure every expressed gene in your exome throughout any cell in your body, roughly 22,000. So you could, without any hypothesis of knowing which expressed RNA you were going after, find a pattern again. And the pattern would kind of fall out in terms of a signature, yes or no. And initially, this was measuring about 150 or so expressed RNA units. But the ability for this to keep learning, it's kind of an iterative process, has allowed more and more RNA expressed units to be added to the test as they try and improve to the next generation. And so now I think the test uses well over 1,000. The key to an RNA-based expression test is that you have to have a binary result because you're looking for a signature. So you can then choose on your receiver operating curve where you put the point to maximize either its sensitivity or specificity and then its predictive values. And then I'll just tell you again the basic story you probably know about the DNA-based test. And so the concept here, again, well over a decade ago, leading really with the BRAF V600E mutation, is that there was really a profound step forward, understanding that well over half of papillary carcinomas were directly related to the mutation in the BRAF oncogene. But you could also measure in the RAS oncogenes, KH and N, and then a series of translocations. The first two off the block were RET PTC, and the second was PAX8 gamma. And that really formed what many of you will know as ThyroSeq version 1. There is no proprietary owner of these mutations. In fact, many different institutes own kind of the patent to each gene mutation. But it's who is able to commercialize it. And you see both Quest out there, and you see CBL Path, UPMC. There's a number of labs. You probably can do it in your own lab to some degree as well. But in terms of what we see kind of commercialized and marketed, we see first there was a version 1, which really was looking at the 17 mutations, and then expanded to version 2, which included an enormous amount of rearrangements primarily, that expanded and improved the test metrics. But what's very interesting, and I'll kind of play off this theme a little bit, is there recently now is the 3rd version of the ThyroSeq test, and to improve the metrics even further, where you see this test going, even though it was initially a DNA-based mutation panel, is to include an RNA expression analysis at the end. And I think that is actually where the field is finding its greatest potential, and you see both, obviously the RNA-based, but also the DNA-based test, making sure that that is included because it picks up on pathways, and I'll explain that. So I want to tell the story and how I see the story, because the story has played out in the course of about 7 or 8 years. So the field has moved awful quick. This seems now like a long time ago for those of us who are in the space, when we had really the initial 4 studies, roughly 2010, that looked at the genetic, the ability to use molecular analysis in the thyroid nodule space as it applies to indeterminate cytology. These were the 4 studies. The hypothesis that is once we could identify these oncogenic mutations, we could actually then use them synergistically for this indeterminate analysis to give us more conclusive information. Or we could create an expression panel by finding out what was expressed in benign histopathology versus malignant histopathology. Those were all very reasonable, good hypotheses. What many of us noticed early on is what I highlight a little bit in red, which is these were fabulous proof of concept studies, very important, but at the same time they sure were limited, or they sure had issues that made us say, are these really translatable and the findings exactly applicable? Just because there was only 24 FNAs in one, there was kind of a selected population in another, there was a non-blinded analysis in a third, etc. And these were the findings. I mean, it was quite remarkable just 8 years ago that we had seemed to found the panacea, that it was nearly perfect. The test metrics, positive, negative predictive values, were hitting almost 100%. But it wasn't just us, I think, and many in this room who just said we just would love to see the kind of broader, more phase 3 type data. It was also the FDA, and I think that's an important kind of backdrop to understand. We're talking really now in the field here about molecular analysis, and in the field of developing an analytic test, it is not anything like developing a pharmaceutical that is applied to the rest of our kind of area. So in endocrinology, if we were looking to develop a new diabetes drug, the FDA, by law, would mandate the formal phase 1, 2, and 3 trials. The phase 3 would certainly be a blinded, randomized, prospective, multi-center trial, and we would feel that that gives us the best data to translate it forward and seek approval. That is not the case for any analytic test, including the ones I showed you up until now. they can really seek and gain approval to market and use the test commercially simply if they've proven analytic validity. In the lab, they understand how to explain, how to reproduce the test over and over. But that has nothing to do with how you apply it to the diverse clinical world. That was the problem we were seeing. And so that I'm going to jump forward now 8 years and just show you what has come about in the last 12 months, which I think is probably an interesting finding. I'll show you one study here that is from Germany. This is from Eslinger and his group that looked at the equivalent of their ThyroSeq1. This is just their own internal 7-gene panel, but is the RAS, BRAF mutational analysis. And when they looked prospectively at a large series, they found a positive predictive value surprisingly low. If you look at a recent data out of Florida, this was Brian McIver's data out of the 2nd generation test. Again, a prospective analysis, you find positive predictive values quite low. And this out of your surgical group here, including Mount Sinai and Cornell, similar values. I show this not to say yes or no to any singular test, but to kind of ask the question, how could something that was so thought to be so good, the positive predictive value of an oncogene was felt to be such an important finding, end up to be so different 8 years later, and how can we explain it? And those are the lessons now learned that I hope I can walk us through. As we do that, this is kind of the good, the bad, the lessons. The promise here of molecular diagnostics is that they have really represented, I think, a major understanding of the disease we deal with, both benign, but more so even thyroid cancer. And I do think when they can be used appropriately and as we begin to understand them more, there will be applications where they will improve care. Nobody wants unnecessary surgery. But the concerns is that very early on, this was a test that was becoming very high stakes, actually. I mean, it was driving an agenda of surgery and a diagnosis in a patient of cancer, which really creates a lot of downstream effects. And yet these molecular tests were becoming available only really based on their analytic validity. There was no clinical assessment, and it was many of us arguing without the blinded high-quality validations, you simply weren't seeing the initial data reproduced well. And so the molecular understanding of disease was just not that simple. So what are some of the fascinating lessons that we've learned, and that we can spend the next kind of 20 minutes on them? And I think I'll focus really on 3. The lesson through the last 8 years has been this. We need to ask really the right questions and avoid some very important leading assumptions. I think we do need to acknowledge diagnostic tests, and the theme I think we all would agree upon is that we need to mandate high-quality clinical validations, those phase 3 equivalents, even if the FDA doesn't mandate them. Let's take them one at a time. I always do a lead-in with this slide, and my lead-in is, though I will talk up and down about the pros and cons of molecular analysis, I kind of do believe in them. I think actually they really are important, and it can be used clinically in a very useful way. We've seen this in other fields, breast cancer most notably. But it's these assumptions that I want to kind of focus on, that first and foremost, I think we assumed early on that molecular analysis could accurately assess malignity or benignity in every nodule, that maybe we don't even need cytology. In fact, the cytologists were a bit nervous a decade ago when this was coming online. I'm going to definitely talk a lot about this second bullet. A genetic mutation means that something is malignant. That is a big, big assumption that we have come to really almost get burned on, I think. Do we understand the meaning of all the data we are uncovering? I would argue no. So what are the lessons learned here? And we'll walk through each of these. We need to ask the right questions and avoid assumptions. So what am I getting at here? This sounds so obvious. What is the right question? The question really at its core, even though we think we know it, I think we lose sight of it, which is how to address the problem of indeterminate cytology. It sounds so simple, but I think the reality is we've taken our lead really in many ways from the thyroid cancer gene atlas, which was fully looking at exome analysis of just a malignant population. And not only that, it was kind of a true malignant population. These were not subtle papillary carcinomas. These were kind of right in the middle classic papillaries. But what we're dealing here is kind of asking, how can we use markers in this field? And even more so, I would argue, it really is using markers just for Bethesda 3 and 4. That's really where clinically we're going to see this, I think, make a difference, and we shouldn't get kind of pulled aside by the other data. So this begs the question, well, what are the kind of populations that make up these types of reports? When you biopsy and get this, what are we seeing histologically? Well, we see clonal populations that are both benign but also malignant. We've seen that sometimes it's hyperplasia that causes these findings. Sometimes it's diseases like Hashimoto's. And it begs the question, why is this happening? How can something that is malignant show something similar under the microscope to something that's benign? And so it has to do with things like this, that benign nodules, when they're undergoing growth or there's inflammation in the area or they're being repaired, even though they're not malignant, can have cellular changes that mimic at times what low-grade malignancies can look like as well. This is kind of my second reason to, I think, emphasize a little bit that it's these pathways that sometimes can, I think, help us as we move this field forward, as opposed to focusing on a single mutation. I think that's why you saw ThyroSeq 3.0 turn to the RNA analysis to take them another step towards improvement. And I think we're seeing that more and more. Why can't you focus just on a mutation? I want to tell a little bit of a story here first to kind of get at this issue that we assumed mutations at time mean something bad. The first piece of data, this came out just last year, but I thought was a fabulous study, was just to ask the question, don't we assume that just malignant nodules mutate, but when we look at benign nodules, maybe they mutate just as much. This was a study of only 21 patients, but a very unique group of 21 patients because they had a multinodular goiter, they had a benign nodule that was proven benign, they had a malignant nodule, and so they performed whole exome sequencing, every DNA base pair in the exome, on the benign nodule, on the malignant nodule, also a sample of the normal thyroid, and then also a sample of the germline from the blood. So it was extensive analysis in each patient. And you kind of see the findings, that the biggest first take-home point is to realize benign nodules mutate absolutely as much as cancerous nodules. So just saying something mutates, that there's a genetic DNA base change, that does not mean anything necessarily that it's cancer. That's why a benign nodule is growing. So you may ask the question then, well, can't you just look at these so-called oncogenes, that the field has come so far, aren't we able to really look in depth and say that if an oncogene mutates, that's just not just any mutation, that's really in a bad pathway. I'm going to share with you what I've shared with some in the room before over the last couple of years, but it's a very telling story because I'm sure at each institution, much like Mount Sinai, you're going to start to see these available to you. This was a story that I got involved in about now 3 to 4 years ago when the Brigham, and in particular the Dana-Farber, introduced a study. And the study was called OncoPanel. And what they allowed us to do is to send any malignant tissue, it wasn't just unique to thyroid, to be analyzed with whole exome sequencing for the 300 most cancer-associated genes that they could identify. This is the list. BRAF, RAS, P53, von Hippel-Lindau, name all your kind of bad genes that you've heard of. And they said, well, send in your tissue and we'll give you the readout. And I thought this was a fabulous thing because first it was free for me and I could quickly amass some data here to kind of keep the field going. So I jumped on it. And the first sample I sent in was of my 53-year-old patient who had papillary thyroid carcinoma, 3-centimeter lesion, run-of-the-mill, kind of typical. And I was very excited 2 weeks later to get the results back. And this is what I received. And I'm going to walk you through it because it's a fun story to tell. The first thing they tell you in the report is that, do you have any so-called tier 1 mutations? And I said, what is a tier 1 mutation? And they said, this is the real deal, that there's good evidence that if you mutate this gene, it causes the cancer that you actually have. And so you should take it serious. And I said, well, that's important. And by the way, in my papillary carcinoma, I had none, 0. I kept reading and they said, well, you have tier 2 mutations. And I said, what is the tier 2? And they said, well, this is kind of important because we think that there's likely some clinical mechanism or utility. There's a connection here to think this is real, and so I said, well, I should take that serious. And lo and behold, in my papillary carcinoma, what pops up is a mutation in the BRCA gene. And for the I'm just an endocrinologist, and even more so just a thyroidologist. And I said, geez, from my medicine training, I thought this was breast and ovarian cancer. And not only that, I have a male patient. And not only that, I submitted a papillary carcinoma. So I really was headed down the issue. Did the sample get screwed up, or what was going on? And I reached out to my medical geneticist, and I said, help me interpret this. What's going on? And he looked and said, what do you mean what's going on? He said, you can have mutations in anything in your body. This is a meaningless mutation. It has nothing to do with the coding region of the gene. It's just an incidental random mutation. You can ignore it. And then he looked at me and he said, and by the way, don't you know that the reason you look like you and I look like me is that we have each 3,000 unique mutations. That's just called variability in our genome. It's nothing bad. And I said, well, that was a lesson. And then it kept getting worse. And then I kept reading, and then it said the tier 3 mutations. I said, what does that mean? They said, well, we don't really know, but we think in animal models that these mutations could be dangerous. So we don't want to act on them too quickly, but they're also not to be ignored. You have 4 mutations in your papillary carcinoma, they said, including P53. I mean, to me, that's a bad mutation, right? Lynch syndrome and that. Again, my friend said, again, ignore it because they're not causing any change in the function of the gene. Just having a base pair change does not mean that you have something malignant.
That's why it should be called a mutation.
Exactly, a variance or whatever we might want to call it. I agree completely. And just to round it out, of course, tier 4. When you look at 300 genes and you ask the question, what does it mean? They say, I have no idea. I had 20 more mutations. Okay, so that was days of work, right, to try and figure this out. A real lesson to me, and it's just a leading issue for the clinicians in the group, and I put myself in that group. We're being asked increasingly to translate data into the clinical world. We certainly get help from our medical geneticists and our pathologists. They're there to help us translate. But remember that some mutations, if you look for them, you absolutely will find them. Most of them are meaningless. So I walked you through 2 things. First, that you find mutations in benign and malignant nodules. Even when you look at oncogenes, you find a lot of meaningless mutations. So you may say, well, just tell me, though, which ones exist in the thyroid cancers, and then let's compare which ones exist in the benign nodules, and that will help us out. And so the leading issue, of course, is that we have the papillary data from the thyroid cancer gene analysis, published now about 2 or 3 years ago, a great tour de force. But we don't have anything that tells us actually the so-called benign thyroid nodule gene analysis. That does not exist at all. So we can't do it. I also want to walk you through kind of the important piece of understanding how to translate the TCGA into the real world. And I begin with this. Of course, in their study, which is keeping with all of the data we have, 60% of papillaries were caused by the mutation in BRAF. That's the top line you see in red. It's important to know when you really look hard at how that plays itself out. How do BRAF mutated papillaries show themselves in the clinic? Cytology is almost always suspicious for malignancy or malignant. Bethesda 5 or 6. It is not Bethesda 3 and 4. These are obvious papillaries because they're often more aggressive. That means that BRAF is not so applicable to using it on the cytologically indeterminate nodules. What we deal with is the green. The second most common finding in papillary carcinomas are mutations in the RAS oncogenes. And that has a real other story that is playing itself out. I'm going to give you some basic data. There's a lot more to learn on this. I don't want to claim we have everything. But we began asking the question, how does RAS itself influence or cause, or how do we think about it clinically as an oncogene? Up till now, almost all oncogenic panels have been applied to cytologically indeterminate nodules. That's appropriate for clinical care, but in understanding how to apply them, we asked the question a few years back, what if we did this to all nodules, any comer, including, all, of course, most of those being benign? So when we applied the basic initial oncogenic panel to about 350 nodules, we found that by far the most common mutation in that panel was the RAS oncogene. But we have such a big and long-standing group of nodules we can follow. We asked how many proved to be benign, how many proved to be cancer, and about half of your RAS-positive nodules are benign. That has shown itself also in follow-up data. The best data, I think, is out of Martha Zeiger's lab, the meta-analysis that really looked and said the same thing. There's lots of benign nodules. But I'm going to draw yourself to the very far right of the screen as well, because it's a small little kind of proof of concept that I think needs to be followed up on, but it's notable. Because many have said, well, if you have a RAS-positive benign nodule now, you're just playing with fire. You just are dealing with a carcinoma in situ, and if you give it time, it will prove malignant. But lo and behold, we were able, through this database, to look and say several of these patients actually were able to be followed long-term by ultrasound. When we looked on average at a 9-year follow-up time in a subset of patients, we found that the nodules did not grow. They were not acting malignant. There were even a selected group of them that had biopsies by chance 5 years apart. They were benign both times. So even that doesn't hold up, that we don't believe that this is necessarily something that will cause malignancy. I don't claim to understand why some of them are malignant or why some are not, but I think we should not assume that these are all going to be malignant. So that is the lesson learned so far, is be very careful with how we think initially about molecular analysis, because it may not hold up. I have about 10 minutes to just walk you through two other lessons we've learned. I really enjoy this story too. The lesson up front, and then I'll explain it, is to acknowledge the practical limitations to any test we're dealing with in the molecular space. I like to lead with a case. You probably have had something like this. A 35-year-old female has a 3-centimeter nodule. It's a Bethesda 3, an atypical reading, and she comes in and wants molecular testing, and you agree. And so she says, you know, I've heard that there's a lot of tests out there. I've been on the internet, and so I want the best one. And she tells you, I want the highest and most accurate negative predictive value. And so can you please tell me which one it is? I'm not going to answer that question, but I'll walk us through this question below. And I would ask you, is a negative predictive value in these tests of 98% really better than 96%? That's a kind of crazy question, right? It's a higher number. It seems better, but why would I ask such a silly question? What I'm getting at here is kind of the concept that how good can we really expect a molecular test to be? Why would there be a limit? Why couldn't everything be 100%? And the leading answer here is this. Any diagnostic test, but in this case, molecular tests for thyroid nodules, are going to base their performance off of an answer, a gold standard. And the gold standard here is the specimen truly cancer or not? Yes or no, right? And so you have to ask the question, which surprised me, and I'll show you some data, how often do pathologists disagree about whether something is cancer, yes or no? Now, some of us are shaking our heads because we've been in the field long enough to know. But just for those who haven't had a chance yet, if you had an error between your experts of 2%, the best your test could be is 98%. If it was 6%, it'd be 94%. So I will share with you a little bit of data from what came out in the middle of the AFIRMA trial that Brian Haugen and myself were part of. And what was happening suddenly was a surprise to Brian and myself, but not necessarily to the pathologist. In this study, we had anything that was removed from the body at one of the 49 sites, which was 760 nodules. We had it analyzed, sent to us, and blindly analyzed by our two expert pathologists. That's Virginia Lavosi at Penn and Juan Rosat. And their job was singular and simple. Just tell us if something is cancer, yes or no. That's all we wanted to know. And so I will ask you, how often when we send samples to the two experts, the leading experts, did they disagree, right? Answer that in your head, because it shocked us that it was 9% of the time. 1 out of 11 times you would send something and one would say cancer, the other would say benign. Think of the downstream impact of that. Even when we said, you guys should really get together and talk this over, because this is really a big deal, they still disagreed 2% of the time. They could not, it came to blows on it. Now, I will argue that these are not the dangerous cancers, right? These are the NIFT-Ps, these are the subtle ones, these are the ones you probably could do nothing on. But nonetheless, as we're applying this in the real world, this comes into bearing. So I think the lesson learned is that I think test perfection here is really unreachable. I think once you hit about 95%, whether it's positive or negative, you should kind of be happy with that. And so if someone comes to me and tries to sell me on something that's 96% instead of 94% or 97%, I just think this is really batting around something that's meaningless, essentially. So you kind of have heard me describe at least my view of the landscape, and I think the excitement of understanding these things, the complexity of how to apply them clinically. But I'm going to end with this, which is just, I want to keep us always focused on what I always want, which is high quality clinical validations. I'll walk you through what I think are the 3 or 4, 3.5. And I will acknowledge there's another big one that is coming out that I just haven't yet seen, though if I missed it in the last week or two, someone will fill me in. I think that's really where the field is at. We're all about high-quality clinical validation. It's the only way we can apply these tests accurately, meaningfully to our patients. I really want the large prospective multi-center trials. They need to be double-blinded. They need to be led by a PI, diverse representative. And I would argue if you take those metrics, we have a couple. And I will go back a decade and say that the Galectin study out of Europe would qualify, even though we don't really apply it here, and I'll come back to that. This was a prospective multi-center blinded trial of about 460 patients, all on indeterminate cytology, showing that if you stained for galectin, it really increased the risk that nodule was cancer. If it was negative, it went down. Whenever I ask my pathology colleagues, my cytologist internal, they tell me we simply haven't been able to quite reproduce the data in the US. for whatever reason. So I see that this is often being applied more to help them histologically than it is cytologically with these indeterminate nodules. Nonetheless, I think it qualifies. We had the chance, Brian and myself and a great team, had the chance to publish the AFIRMA data in the New England Journal and lead that study. This was a very big study. It enrolled roughly 4,000 patients. It was 49 clinical sites. It was all the standard high-quality metrics that we wanted, and we really maximized. We pushed the company to say on that receiver operating curve, we really want the maximum sensitivity so that you have the best negative predictive value. And I think what we've seen is that NPV at least has held up, that nobody has died of a false negative AFIRMA, and I don't think they ever will. I think that's reasonable to stop the train. When I said 3.5 clinical trials, they've updated, as all of these tests do, keep improving. They now have a second generation. They call the genomic sequencing classifier. GEC has turned into GSC. And what they've done is simply add more expressed RNA units. So instead of 200, now they're trying to use 1,000 or a little bit more to help them. And indeed, they have improved metrics. As you notice, it didn't really help the negative predictive value. It helped the positive predictive value a little bit. And I think that's good. This was not a full-blown repeat validation. That's why I used the word half, 3.5 studies. This was kind of reanalyzing this new test on the data we had collected in 2012. So take that as you will. I was a part of, I think, the third or fourth big randomized trial as well. This was back when a surgeon was trying to put forth their test before they became Interpace. And at the time, this was using the equivalent of ThyroSeq 1.0, the very earliest of the platforms. There were 5 sites. And surprisingly, we could not reproduce what was found in the UPMC data. And it was all about this RAS positivity. This was the story where we talked about lower positive predictive values. Now, with their second and third generations, they have significantly increased the NPV. And I think that is an interesting story, isn't it? That the DNA-based tests were sold as rule-in tests, the RNA-based as rule-out tests, but they're actually all turning into rule-out tests, which I think is what we want, actually, as clinicians. These are old data right now, and I have at least seen at the last year's ATA in Victoria that there were data presented in the Expo Theater, so I don't want to share them. That's not a venue that I think is quite yet in publication, where they have actually done a multi-center randomized trial that is on their third generation that showed what appeared to be very good metrics. I just haven't seen it published yet. For whatever reason, that was October, and now we're in June here. So hopefully I've walked you through these last, and I can finish with these last 2 slides, and I'll kind of, I think, show you the reality of what we all know, that the real world is diverse and variable, that we have diverse practice patterns, that we have diversity in our populations, that we have some variability in what an expert interprets, and that's life, that's clinical medicine, right? For those of us who are clinicians, doesn't mean anything bad or good. But all those things are feeding into these tests. And if you ask why phase 3 trials are so important, it's because we have to understand how everything plays out when you have these factors, because it will never disappear. And it's explaining a lot of why we're seeing the differences in published experiences. So I asked the question, can we do better? I want to leave us on a very positive note. I do think we're doing better. I don't think the old standard for 4 the exact standard we stick to. I think we keep moving the field forward, but we do so in an academic and logical way. And with a real sincere thank you for inviting me down, having the chance to come down to the city and see all of my old colleagues and friends. It makes me feel older to know everyone now for so many years. But that's a good thing. It's a good thing. I'll end with my conclusions, which is kind of molecular diagnostics, nodules, and really the lessons we've learned. Which is, I do think we're improving care when we use these in a smart and intelligent way and for the right patients. But I think I've also shown you that diagnostics here in the thyroid are really complex, and it's more than meets the eye. The tests are improving, and credit to the companies, because industry helps to move this faster sometimes than we can do in the academic arena. That we've seen second generation, third generations of the test. I think these will continue to improve. I do think there's something about analyzing a pathway that is superior, and that's why you've seen both of these tests add on the RNA expression to them, and so we'll see where this goes. Remember, a mutation or a variance, as Andrea said, is not anything that means malignancy all the time. We need help in understanding which ones are bad and which ones are not. We don't know that yet. But be thoughtful as we all interpret the data. I think it's really these high-quality investigations, these phase 3 equivalents, so-called, that will help us really translate the durable data into our into our clinics, and I think we don't have it for microRNA. I'd be very cautious in that space right now. I'm happy to take questions on it, but I think we have two leading tests that are really helping us quite a bit. And with that, we do have many questions left to answer. Thank you so much for the chance to be here today. I would absolutely take questions. Yeah, I would take tough questions, definitely. Yes. Anyway, please.
Multiple mutations.
Yeah.
So they're uncommon to rare.
Yeah.
But if you had, the old recent literature 3 or 4 years ago, if you had a TRAF and a TERT, and maybe a KRAS or something.
Yeah.
I have a couple of patients who are personally convinced, have looked at the literature, that they're going to be in real trouble, and they're getting more radiation and more radiation.
Yeah. I think you've raised a very good point, which is the uniqueness of thyroid cancer is that it's been most of the time, fairly indolent malignancy, and therefore we find typically one mutation. It's quite conserved in terms of many other malignancies which continually mutate at a faster rate. But when we do see two mutations that we think are meaningful, that has clearly been shown. In particular, the BRAF and TERT are the two that Ming Zhao has really shown and published in JAMA, really speak to a more dangerous scenario. I think, though, it was also that finding that led us to make some assumptions that, for example, RAS was more dangerous than we thought, because back in the selumetinib data, that was also the RAS, some of those very advanced cancers had RAS mutations in addition to other mutations. So we just have to be careful that, yes, I think you're onto something, but we want to not overinterpret then what each mutation means. In combination, they are worse. I agree.
Yeah, I guess, first of all, fantastic talk.
Okay.
So thanks for bringing this all up. I guess the big sort of elephant in the room is we don't really know what bad disease is until 20 years ago.
Yeah.
And you said that yourself. So you're trying to guess at a positive predictive value in a way that pathologists can't agree on what's malignant and what's not.
Yeah.
What's nasty and what's maybe not so nasty. It's very hard. So this is that going back to older tissues that are, new paraffin and formula from 6 years ago, looking at long-term outcomes in that population. Of course, they were doing biopsies and they don't have any determinants.
Yeah.
Just was the issue of the definitive long-term outcome data are hugely important that we don't really have.
No, I think you're absolutely right. I think the other piece to that is we've entered this world and the molecular analysis of this world with kind of what was cancer 30 years ago, right? And I think you've seen now, and the best example is NIFT-P, really being called not quite a cancer, even though we surgically remove it. And maybe that's the issue, is that we should be calling thyroid cancer just the far right of the spectrum, right? The bad stuff that's showing lymph node disease early on. I mean, downtown, Mike Tuttle always says, you know the bad stuff when you see it initially, right? The rest you can probably ignore. And I think that's probably true. And what he's getting at is when they present kind of with the more aggressive nodes, those are the ones who are going to recur. But the isolated little thing in the gland, you could probably leave. I think the field is clearly moving to be more conservative.
So Erik, is that how you're practicing?
I'm trying. I'll tell you what the dilemma is, that all of us as clinicians in the room know that when you're talking to a patient and you're under pressure to do this in 14 minutes and bill for it, it gets very hard to sit down for an hour and tell the patient over and over and over, you can do nothing. But they say, I had cancer. No, you don't really have cancer. What do you mean? I'm going, and so it's the translation into the sociology of medicine that has made this equally complex.
In terms of clinicians, as mostly saw real clinicians, do we get a good history of radiation, the amount of radiation, when it was done in the elderly, it could have been given for acne, and later are there data connecting a mutation or degree of mutations to the degree of radiation?
So generally, no. I think you're absolutely right that there is, in my experience, very little ability to connect the radiation someone said they may have had or they did have as a child, knowing what that really means, because the data are so old and the machines had much more scatter back then, and it was hard to know where they did the whole thing. And you just kind of are left saying, I don't know. So we mark it in our chart that there's radiation exposure, but we find there's a lot of variance. the answer to your question as to are there specific mutations that seem to come out of radiation exposure, the best data is from Chernobyl, and that's the RET PTC actually, and especially in kids. For whatever reason, when you're under roughly 14 to 16, you seem much more predisposed to malignancy from that effect than you do as an adult.
Thank you again. Terrific talk. Thank you, Dr. Davies, and thank you, Dr. Siegel, for bringing Dr. Alexander. Just to support one of your clinical anecdotes, I was sent a patient a few years ago. She was 90 years old. She was sent for osteoporosis, but she had a well-treated malignancy. I felt a thyroid nodule. I called her oncologist to tell him that, and he hung up the phone on me. He said, unfeeling.
That's right. That's classic New York right there, right? I love that. I love that. Right, so the question was how much of that weird change in the DNA-based test from being a rule-in test to kind of really becoming more of a rule-out test could be related to inclusion of other higher-risk gene determinants Bethesda 5. I think it's probably the minority because at least from the practices I've talked to, and I haven't done a full-scale study, I mean, really from the start we pushed hard against using molecular analysis in Bethesda 5, unless you had a unique reason to consider it, or a high-risk patient, you were really trying to avoid surgery. So my hope is that I was not missing something big around the nation, but I think it really is just an understanding that the reason that happened is that we assumed RAS and other mutations meant malignancy because we were doing things in a non-blinded fashion, and we equated a mutation with malignancy. And suddenly, though, this understanding that if you did rule out a lot of those things, that maybe you were finding, I bet, other mutations that we don't know of yet that are causing benign growth, right? So it became more of a rule-out test, I think.
So I sent a patient to a surgeon I don't usually send to. It's a very good thyroid surgeon with a suspicious affirm last week. And the surgeon called me and she said, well, the patient would really like to know, does she have malignancy? So would you be kind enough to repeat your biopsy and do a thyroid?
Oh yeah, I mean, right. This is what's happening. I agree.
Worse, sort of.
Yeah, it was a great. I mean, part of the fun of this field too has been that it at times can become contentious, but I think we're all good colleagues. Yuri, myself, Brian MacGyver, all of the people who've been involved. And Brian MacGyver, not Haugen, did a talk with Steve Hodak, who's uptown, a couple of meetings ago, and kind of the unique weirdness of these permutations we're finding now in the clinical world, like multiple tests being done, repeat tests being done, molecular tests being used on benign cytology, right? That's a real no-no. Don't go there at all. So I agree. I think that is up to us as kind of the leading endocrinologist to kind of inform the general practitioners in the world of how to use a test appropriately. So I know you all have patients to see, so I'll stay up here, but I really want to see you all today.